Good evening, everyone. Thank you for joining us on a beautiful Tuesday evening. This is one of our Midwest Vascular New Horizons webinar seminar series for August. And tonight we're going to be talking about VTE updates for 2025. So we're excited for everyone to be joining us. We are sponsored by Penumbra this evening, so we'd like to thank them for their sponsorship. And first up, we will be hearing from Dr. Angela Martin. She's a vascular and general surgeon at Evansville Surgical Associates. She's also medical staff president for Ascension St. Vincent Hospital and regional clerkship site surgery director for the Indiana University School of Medicine. So she will be talking about should we treat all acute iliofemoral DVTs.
Okay, thank you, everyone. I'm going to be talking, like we said, about acute iliofemoral DVTs from Evansville, Indiana. So just as a disclosure, I am a consultant for Penumbra and Silk Road Medical. So just as a quick kind of recap of some of the best data that we have for iliofemoral acute DVTs, there are 3 randomized controlled trials that address this topic. The first one, the CAVENT, has 209 patients enrolled. And really all 3 of these are mostly catheter-directed thrombolysis, not thrombectomy. The first trial was in Norway, published in 2011. And it did show a 14% absolute risk reduction in post-thrombotic syndrome, which is one of the big reasons why we recommend or typically do treatment for iliofemoral DVTs. The ATTRACT study, which is the most robust, involved 56 centers throughout the United States. This was published in the New England Journal of Medicine in 2017. And it did not show, excuse me, a big difference in post-thrombotic syndrome. However, when you specifically looked at the iliofemoral subgroup, then it did show decreased swelling and a faster recovery from the thrombotic events. In that study, additionally, they did suggest or recommend single session lytics and possible thrombectomy. They had angiojet and trellis products available for that trial. And again, stenting if there was a more than 50% diameter reduction in the iliac vein. And then the last one, the KEVA trial from the Netherlands that used 15 different hospitals were part of that study. And they typically used ECOS catheters for that trial. They did show some less post-thrombotic syndrome. However, it was not statistically significant. Nowadays, we do have some newer devices, certainly than any of these trials, which makes it a little bit harder for us to truly know what is the standard of care, what is the right thing to do for these patients at this point in time. None of these trials specifically had Inari products, Penumbra products, JEDI, or several of the other options that we have nowadays. There are newer trials underway. Penumbra has a BOLT DVT study that is a prospective multi-center trial. Additionally, Inari has their CLOUT registry, which is working towards 500 patients. And really, post-thrombotic syndrome is the big factor that we're looking at in these patients, in addition to DVT recurrence. We do know that with iliofemoral DVTs, there is a higher recurrence, about 2.5% increased risk of recurrence compared to just femoral popliteal DVTs. There's also more post-thrombotic syndrome and more severity to the post-thrombotic syndrome with iliofemoral DVTs, which is why I think most of us tend to be more aggressive with these. So I'm going to just talk quickly about one patient that I took care of. I'm not certain how many DVTs most of you guys have managed. I think I've had at least one of every complication you can possibly have from DVT work. And prior to this procedure, I had a pretty traumatic experience where I'd accessed the popliteal vein in a prone position and ended up converting a DVT case to an emergency PE case in a very unpleasant fashion. If you have not had to do CPR from a prone position, consider yourself fortunate, because it was extremely troublesome and difficult to get that patient through it, which they did, thankfully. But so as a result of that, this procedure, I'd heard people talk about the importance of opening up the profunda femoral vein if at all possible. And so for this procedure, I decided to go up and over I used a penumbra 16 French sheath. So this was a young gentleman. He was 26 years old. It was very acute clot, his first time, never had a DVT before. And I'm not certain about your institutions, but in ours, typically the ultrasounds don't really go above the common femoral vein. And so in this individual, we knew that there was clot in the common femoral vein, the profunda, the superficial, and they could say maybe a little bit in the external iliac what they could see. And so I typically presume when there's that level of clot, probably the entire iliac vein, common and external, are thrombosed. He had no PE, so I gave him heparin overnight, and in the morning I took him. And so what I did, again, I used a snare and I went up and over in a body floss technique with the 16 French system. And I worked specifically not only to get the iliac vein cleared of thrombus, but also the profunda femoral vein. And I was successful. I don't have great completion pictures. By the end of the procedure, he was pretty squirrely and pretty sick of laying there. I think it was about 90-minute procedure. It took longer than certainly I would ideally like. And the pictures at the on the right side there just shows, with the catheter up and over, running into some valves. Some of the valves don't bother, don't really have much competence and don't cause you trouble. But in him, that's about as far as I could get on the right picture with my catheter. And then certainly took the 16 French system to about that depth as well. So we did get a good result. He does have factor V Leiden that was confirmed after this procedure. He is on lifelong anticoagulation. At this point in time, he has had near complete resolution of the swelling and is, in much better shape. We do know that he still has a little bit of residual femoral popliteal DVT, but certainly the iliac veins, to our knowledge, last I saw him a couple months ago, were still widely patent. I did not stent him. So that's all I have, picture-wise, slide-wise. Thank you guys for your time.
Thanks so much, Dr. Martin. It's a real pleasure to be working here alongside Dr. Morgan to moderate this session on DVT and PE, near and dear to my heart. Next up, we have Dr. Khalil Kato discussing when do we intervene on chronic DVTs. Dr. Kato is an associate professor of surgery at SIU School of Medicine. So thanks so much for joining us, and I'll turn over the mic to you.
Thanks, Nick, and thanks for the Midwestern Vascular for the invitation to speak and for setting up this webinar. So I'm going to be talking about chronic DVT, and by no means is this all-encompassing. I have no relevant disclosures. So just a quick definition. As we know, acute DVT is a thrombus that is less than 2 weeks old. Subacute is thrombus 2 to 4 weeks old. And chronic DVT is referred to if the thrombus is estimated to be have been there for greater than 1 month. But I think it's important in this discussion to differentiate between 1 month chronic DVT and 4-year chronic DVT. As the thrombus is in the vein, it becomes a little bit more organized. The vein itself becomes a little bit more scarred as a result of the inflammatory process. So it does change the kind of approach to treatment and the thought process going in. So as we all know, DVT is a very prevalent disease process. And when we talk about the management of DVT, especially when we think about intervention, we worry about post-thrombotic syndrome. And this occurs in about 20 to 50% of patients with DVT. And this is essentially chronic venous insufficiency as a result of that DVT. Obviously, there's other causes of chronic venous insufficiency, but with post-thrombotic syndrome, we're referring to that in reference to outlet obstruction. So for chronic venous insufficiency, there's a SEEP classification. It begins with small varicose veins, telangiectasias, all the way up to edema, a healed ulcer, as well as an active ulcer. And I think this is an important consideration, especially in those patients with the chronic DVTs. So for the mainstay of treatment for chronic DVT in general is anticoagulation, leg elevation, weight management if the patient is obese. Compression therapy is important to reduce the edema and venous hypertension. And often I'll start with the 20 to 30 millimeter mercury compression stockings, and then move towards a 30 to 40 millimeter mercury at, if they're able to tolerate the 20 to 30 initially. If there is a venous ulcer, obviously you want to consider compression therapy, as well as intermittent pneumatic compression devices. So when do we consider some sort of surgical or intervention? So generally for chronic iliocaval DVTs with severe post-thrombotic syndrome, with active ulcers or non-healing ulcers, if there's significant lifestyle limitations, including pain, as well as those that are refractive to medical and compressive therapy. And the goal in treating this is to decrease the luminal obstruction and thus decrease the ambulatory venous hypertension, which should hopefully prevent worsening of their symptoms. So this is just a study. It's about 10 years old, by Dr. Arco's group, looking at the endovascular treatment for acute and chronic DVT. And I thought it was helpful because it sort of is important to differentiate these two disease processes and the thought processes and how the outcomes should be expected. So as you can tell in this, the patency rates are not that bad, but obviously not significantly, but definitely worse in the chronic DVT group. In general, the differences in treating the acute versus the chronic DVT, understandably, thrombolysis is less effective. They did use that in 28 of their patients. And overall, there was less thrombus clearance in the chronic DVT compared to the acute DVT. There was also more likelihood to use adjunctive procedures, such as angioplasty and stents, as well as thrombectomy. And interestingly, the main significant factor there was significantly worse valvular competency after thrombus removal. So in acute DVT patients, they had 78% valvular competency versus the chronic DVT of 39%. And I think this is important because even after you treat a patient with chronic DVT and you get rid of the luminal obstruction, you still have valvular incompetence. And so they'll still need compression therapy afterwards as well, which is important to consider. So when you consider the management of endovascular treatment of chronic DVTs, I'd like to separate them for those that are older. I guess you could say greater than 1 year, sort of an arbitrary number. These are generally patients that you'll see extensive collateralization, such as in this patient. This is not my patient, but and you'll usually have to use some angioplasty and stenting. I don't usually use any sort of thrombectomy in these patients. Usually, maybe if I think there's a subacute component, I will. But otherwise, it's generally angioplasty and stenting. For the subacute patients, this is usually mixed thrombus with some acute as well as chronic. And for these, I'll definitely begin with some debulking with thrombectomy, plus or minus lysis. And then depending on IVUS imaging and venography, I'll either angioplasty or stent. So I just wanted to discuss a case that actually I did last week. This is a gentleman who had a prior femoral popliteal DVT on the right, was on anticoagulation. However, 3 months prior to his this admission, he stopped his anticoagulation due to a brain bleed. He had an IVC filter placed, and he presented with worsening swelling over the past 1 month. We got the clearance from neurosurgery to anticoagulate him. We got a CT scan, which showed extensive iliocaval thrombus. So we took him to the cath lab, accessed his right common femoral vein, and you can see here has a pretty extensive thrombus throughout his iliocaval segment. We used the computer-assisted vacuum therapy with the lightning flash. And I think, it's important to, I hope this video works. One of the techniques that I think is helpful is, you got to be somewhat aggressive with trying to get the thrombus out. Now, I think in the chronic patients, sometimes advancing that catheter can be challenging. So you may want to angioplasty beforehand. But you can be a little bit more aggressive with the penumbra catheter. You won't really damage the vein. And so this was our completion of the iliocaval segment. As you can see, we definitely got a mixed result in terms of the thrombus. There was definitely some acute, but also some significant chronic component to it as well. And he had a great result and was discharged on hospital day 1, and swelling was already, kind of markedly improved. So thanks again for the invitation, and looking forward to a good discussion.
Thanks so much, Dr. Cato. That was a great talk. We're going to move on to our next one. We have Dr. Vipul Khattarpal. He's an associate professor of vascular surgery at Washington University. He was an early adopter of PE interventions and really helped establish the vascular surgery presence on his PERT team at WashU. So he's well equipped to talk to us about a vascular surgeon's involvement in PERT.
Thank you. I have no disclosures. As we all know, pulmonary embolism is one of the leading causes of cardiovascular mortality in the US, accounting for almost 600,000 patients annually with about 100,000 deaths. The survivors can have very debilitating complications affecting their quality of life. So we need to have a very concerted collaborative effort amongst very diverse stakeholders to address this issue. There is a huge need at the moment in the PE space to have evidence-based direction for the treatment protocol. The PERT process itself, the inception started in 2008 when the Surgeon General addressed the need for more efforts in the DVT and PE space in the US overall. In 2012, MGH came up with the first collaborative PERT process. And by 2015, over 70 or 80 providers got together in Boston and came up with the PERT consortium. As of 2016, only 15% vascular surgery involvement was noted within the PERT consortium. And in 2017, there was a pivotal article written by Dr. Ross in Vascular Specialist calling attention of all vascular surgeons to participate in PERT and be on the cutting edge of treatment for this process. We did a survey in 2023 that still showed that vascular surgery involvement is only around 23% in PERT processes. There have been numerous articles over the last decade talking about how important PERT is in managing outcomes for patients with PE with lower rates of all major and clinically relevant outcomes, including bleeding. There is a shorter time to therapeutic anticoagulation with the inception of PERT, decreased use of IVC filters, and almost 50% decrease in 30-day mortality without increasing the demands on the hospital. The adoption of a multidisciplinary team is associated with substantially lower readmission rates, and all-cause mortality of these patients is substantially lower as well. We went on to try to understand what is the vascular surgeon's involvement in the PERT process, and recently published this paper. This was a survey audit by the Vascular Collaborative Group. We had 139 vascular surgeons respond to it from 19 countries. 80% of the respondents were from the US. And on an average, the surgeons who responded were mid-career. They almost had 10 years of experience under their belt, with 70% respondents from academic practices. The vast majority of these vascular surgeons were already doing deep venous work and IVC filters, et cetera. So they were already kind of engaged in the deep venous space to some degree. Amongst the people who responded, only half of them had a formal collaborative PERT process in place at their institutions. And out of which only 23% were involved in PERT. So we went on to ask them other questions as to why, what their involvement was, et cetera. The vast majority of involvement in these institutions was from pulmonology, interventional radiology, and interventional cardiology, with vascular surgery lagging substantially behind in their involvement in the formal PERT process. When we asked them if they felt that they were fairly represented in the PERT process, about 38% of them felt that vascular surgery was grossly underrepresented in the PERT process and needed to be involved. We tried to delve down deeper into what the barriers of vascular surgeons' involvement in the PERT process was, and it boiled down to intraspecialty competition, where there was a lot of turf war or competition with other specialties within the system. Operationalizing the call schedule was a challenge for a lot of the physicians with a lot of time constraints, where they had heavy clinical workload on call, which made it very difficult for them to participate in the PERT process. There seemed to be a lack of interest from some vascular surgeons, which on delving down further also stems from lack of familiarity for a lot of vascular surgeons in this space. And lastly, there was a lot of administrative, there were administrative issues like availability of a cath lab space, availability of a hybrid room space, and lastly, they felt that lack of marketing was also another barrier for their involvement. Now, vascular surgeons as a whole are key members in PERT. They are very used to high stress situations warranting measured and accurate responses. So we are perfectly positioned to sort of deal with acute PEs. We need to remain as a group very relevant and practice cutting edge interventions. This space is huge at the moment, and there is a huge need for evidence-based practice guidelines. And just like other spaces like CLTI and aortic work, I think vascular surgeons are very suited to be on the front lines of the pulmonary embolism space, so we can come up with better directions where we need to take the space in. I think instead of seeing this as a whole new avenue, we should see this as an existing extension to our DVT and venous practices. And the actual draw on our time and resources is far less expected once you have a formal PERT process that you're able to form in your institution with huge amount of satisfaction after doing a PE case because of great outcomes. Collaborating with partners within the hospital also opens up great channels of communication and better referral pathways for even other kind of cases that you would want. I think at least in academics, training the next generation and increasing the awareness for PERT involvement is going to help vascular surgeons position themselves in a better position to guide care for PE in the future. This is a 49-year-old female that I treated a few months ago. She had distal splenectomy for neuroendocrine tumors. She had portal venous thrombosis and was put in Eliquis, but a month later she came back in with surgical site bleeding and her anticoagulation was stopped. She developed sudden shortness of breath and was noted to have significant pulmonary embolism with RV strain based on CT and echocardiogram. She was started on anticoagulation, but within a few hours, she had cardiovascular collapse and had CPR for 2 minutes. She was emergently rushed to the operating room, and the CT surgeons put her on VA ECMO, and we proceeded with concurrent pulmonary embolectomy. These are CT scan slides representing her clot burden. As you can see that there was no saddle PE component, but the clot on the right side was occlusive and left lower lobe was occlusive as well. In a standard fashion for pulmonary embolectomy, we use a CAT16, and now we're using the Flash 2.0 algorithm with that. I normally always take a angled pigtail catheter to select the PA. There are other options available, which are like arrow catheters with balloon tip catheters to help guide across the heart into the PA. In this case, we did not check any PA pressures because she was in distress at the moment. We routinely try to put at least an 18 French or a 20 French blow-dry sealed sheath in the main PA prior to using the CAT16 because I feel like it helps you support the catheter better, and then you can torque more with the catheter itself. The second image here shows that after a few passes in the middle and the lower lobe on the right side, you can see all that clot has resolved, which is very easy with this device. And there is some clot remaining in the right upper lobe, which we then selected and cleared out. Similarly, we treated the left side in a selective fashion, and the completion imaging showed resolution of all proximal truncal clot with improvement in her hemodynamics. She was then decannulated 2 days later by CT surgery percutaneously and developed a large pseudoaneurysm at the closure site, which required complex open repair. She was in the hospital for approximately 18 days for a variety of other issues not pertaining to her PE, and was discharged with normal RV function and normal PA pressure and echo. And long-term, she has been established in the PE clinic with pulmonary critical care for long-term monitoring and has been doing really well. Thank you. I'll be happy to take any questions at the end.
Thank you so much, Vipul. Always great to see your cases. Next, we have Dr. Adam Reichard from Good Sam to discuss his algorithm for PE thrombectomy. Dr. Reichard is Associate Program Director for the Vascular Surgery Fellowship and Integrated Vascular Surgery Residency. He's also the co-director of the Center for Advanced Endovascular Aortic Interventions. So, Adam, with that, take it away. Thank you.
Thanks. Let me pull my slides up here. Is that coming across okay in presenter mode?
Not presenter mode yet. Yep.
All right. I first wanted to thank Midwestern Vascular for the opportunity to speak and also for organizing this webinar. And also thank you to Penumbra for the sponsorship. As far as my disclosures, I am on the Speakers Bureau for Penumbra. I'm going to cover some of the technological information regarding the new Lightning Flash 2.0 computer-aided vacuum thrombectomy catheter. There's been a rapid evolution of endovascular thrombectomy, and I won't go through all this, but this has sort of led to computer-aided vacuum thrombectomy and why that's important. Obviously, when we're doing these thrombectomy procedures, probably the most important thing is safely being able to remove thrombus. And also, we want to try to mitigate blood loss as much as possible during these procedures. This catheter has a dual detection algorithm, which basically leads to those two things: effective thrombus removal while limiting blood loss. The good thing about the new catheter, as opposed to Lightning Flash 1.0, is there are two modes now. So there's a sampling mode when you see a green light, and then there's a gallop mode when there's either thrombus at the tip within the catheter or within the tubing. And you'll see the yellow light, and it's got that pretty obvious gallop sound to it. Like I said, there's a dual clot detection algorithm. It's both pressure based and flow based, which allows for quicker clot detection, and also the ability to more quickly recognize when you're in patent flow, so it's not aspirating blood when you're not within thrombus. And that obviously mitigates the blood loss during the procedure. It comes with two tip shapes. There's an X torque, which is what I actually prefer during the PE procedures, which comes in 100 centimeter length. And there's an H torque tip, which comes in 3 different lengths of 80 centimeters, 100, and also 115 centimeters. It's also packaged with a select catheter, which is, it comes in handy for a couple different reasons. One, whenever we're tracking the device up, I know some people use a 65 centimeter Gore dry seal sheath. We tend to use a 33 that we leave in the inferior vena cava. And once we get our stiff wire up, we actually place the select catheter through the thrombectomy catheter, and we telescope the thrombectomy catheter over the stiff wire in the select catheter. That's really eliminated the need for us to put a long sheath up through the right heart into the right ventricular outflow tract. Has multiple applications. We know it can treat pulmonary emboli as well as iliofemoral and iliocaval DVTs. As far as the aspiration effectiveness and power, it's approximately 8 times more powerful than Inari's FlowTriever, which is 24 French. And it's actually 3.2 times softer, which allows for easier trackability. So, we do PE thrombectomy procedures on patients that are high risk on ECMO, and I was initially going to present one of those cases, but I thought it might be better to present more of a run-of-the-mill kind of boring thrombectomy case that, this is what we would prefer to do. We like these cases to not be too exciting. Our patient's an 81-year-old female. She presented with a chief complaint of shortness of breath. She was having some intermittent chest pain, and she actually had a pre-syncopal episode as well. On evaluation in the emergency department, her heart rate was in the low hundreds, blood pressure 121/87. There was not a sustained drop in her systolic or anything like that. She was not tachypnic, and she was satting 98% on 2 liters nasal cannula. She got a CTPA, which I'll play here. And you can see that she has a saddle pulmonary embolism with a pretty significant thrombus burden in the bilateral distal main pulmonary arteries. So we actually utilize an artificial intelligence platform here at TriHealth, VizAI specifically. It has been pretty much a game changer for us here. It's rapidly increased the multidisciplinary buy-in from all the other services that participate on PERT. There's a HIPAA-compliant communication platform sort of built into this, and that allows us to communicate with all the other services and sort of quickly come up with a game plan on whether or not the patient needs a procedure, disposition. But I think more importantly, we've noticed that it's getting patients therapeutically anticoagulated much faster. So Viz will read a CT scan as soon as the scanner is done spinning. So we get a notification on average around 4 or 5 minutes. And once it's identified, then, sort of the first question on the communication part of that app is who's going to notify the emergency department or the floor that that patient needs started on heparin. This patient's cardiac biomarkers, troponin was 777, BNP was 46. Most of the patients that we do a procedure on, they end up getting a transthoracic echo first. I think you get some good information from that. This patient had right ventricular dilation with a reduced systolic function, reduced TAPSE. Their RVSP was elevated. As far as the procedure, we made the decision that this patient needed a thrombectomy. She sort of checked all the boxes for an intermediate high-risk pulmonary embolism. We triage these like everybody does based off the same sort of metrics. This is actually a case of one of my partners that he did last week. Dr. Kowicki did this case, and we tend to access the common femoral veins if possible. It's infrequent when we have to access an internal jugular vein, but that's obviously a possibility. We like to use ProGlides, which is sometimes an unpopular opinion. We're pretty aggressive about getting these patients anticoagulated before they leave the cath lab. So using a closure device sort of helps with kind of workflow and keeping the day moving. So someone's not holding pressure for 20 to 30 minutes after the case because we haven't reversed heparin. We start with an 8 French sheath. We get a stiff wire in, then we immediately upsize to a 16 French 33 centimeter gore dry seal sheath. Like I said, we like to use the shorter sheath and leave that parked in the cava as opposed to putting a longer sheath through the right ventricle. And we cross the right heart with an angled pigtail catheter. You can see here we have the angled pigtail catheter up in the main pulmonary artery, sort of cheating towards the left side there, and there's a pretty significant thrombus burden. It's not totally occlusive. It's not like one of the ones you see where you're not really getting in much perfusion at all to the lung. Like I said, we'll tend to get a stiff wire up. We use a 1 centimeter floppy tip Amplats. We'll put the select catheter through the thrombectomy catheter, and we'll kind of park the select catheter at the tip of the stiff wire, and then we'll telescope the thrombectomy catheter over it. And like I said, that's basically mitigated the need for us to put a long sheath in. And you can see after a single pass, the majority of that thrombus has been aspirated. There's still some thrombus in that left lower lobar branch. And on a subsequent pass, you can see that that was aspirated. Preferentially, I feel like probably 90-95% of the time, your pigtail catheter is going to sort of pick the left side. So selecting the right can be a little more difficult, and it can certainly be a little more difficult to get your catheter to track. The way I do that is I'll put the select catheter back in and pull the thrombectomy catheter back to the right ventricular outflow tract, and then we'll use a glide wire, which is also sometimes an unpopular opinion, but I think if you're safe with it and you're not being too aggressive, you can use it to at least select, and then we'll exchange for a stiff wire and telescope thrombectomy catheter into the right side again. You can see on the right side, this isn't the best run, but there is some pretty significant thrombus and pretty much the distal main and more in the right lower lobar branch there. And after a single pass, that right lower lobar branch was pretty much cleared. And then we had a final picture here showing that the upper lobar branch was also cleared there. Like I said, we tend to use the ProGlides to kind of get the access site closed, get the patient back on heparin, and get him out of the cath lab. Obviously, you know, speed is not the goal here, but you know, I just had a case this afternoon for a lady with an intermediate high-risk pulmonary embolism, and we were stick to closure in about 30 minutes. We do check pre and post-procedure pulmonary artery pressures. I think that probably the hardest thing when I started doing these cases was to know when to stop. And I mean, you have your angiographic pictures to go off of, you monitor hemodynamics during the case, and you can see their heart rate start to come down, maybe their oxygen requirement starts to come down. If you're doing a high-risk patient that's on vasopressors, hopefully you start to see their vasopressor requirement come down. But I think that if you're checking pre and post-procedure pressures, it gives you some more objective data to know when it's okay to stop. And we're usually looking for about a 20 to 25% decrease in the pulmonary artery pressure from when we started. I will stop there. I have some more slides on some, you know, using compromised blood, using a different device, but I think that might take up too much time. So we'll keep moving.
Thanks so much, Dr. Reichard. So at this point, we are going to open it up for some Q&As. So we can utilize the Q&A function. I believe that the audience should be able to submit questions, and then we will read them out to our panelists. So as we're getting, I don't see any questions currently. So, for those of you in attendance, why don't you send along any questions? And to start, I really appreciated Dr. Ketterpaul's talk about the importance of a PERT team and how there really is a lack of vascular surgery involvement. So I was going to ask all of our panelists what it looks like at their institutions. Are you involved in your institution's PERT team, and who all is at the table?
I can start. We are certainly involved in the PERT here, and we're in a unique situation where our vascular surgery group, which is 6 of us, we're the only interventionalist for pulmonary embolism, emboli thrombectomy. So I think that's a little unique. I mean, it's still certainly multidisciplinary when we're decision making that involves us, pulmonology, critical care, cardiothoracic surgery. But here it's the vascular surgeons that do the procedures.
I'll go next.
Sorry, go ahead.
Oh, go ahead.
I was just saying that's in Evansville. It's vascular surgeons that do all the interventions pretty much. We do work with the pulmonologists and the emergency medicine physicians, but it's pretty much on us.
Yeah, here at SIU, it's mostly the interventional cardiologists for the PEs, and then we'll do the DVTs.
So for WashU, we split the interventional call with interventional radiology 50-50 at this point in time. Pulmonary critical care, hematology, ED, or surgical critical care also participate. CT surgery selectively participates depending on whether or not we feel that their input is warranted for ECMO.
With regards to the PE, while we're waiting for more questions, and the PE interventions after the post-PE care, are you, as vascular surgeons, involved with that, or does that get completely transitioned to cardiology or pulmonary hypertension team? I mean, what's your involvement or follow-up after the PE intervention?
So for me, I used to, before the formal PERT process, when we initially started it, I used to follow all of them in my clinic. I used to follow them through their hospitalization, and then at 1 month mark and 6 month mark, I used to see them with echocardiograms and used to coordinate with hematology. Fortunately, we have a PERT clinic now that is run by pulmonary critical care. So all of them are plugged in with a pulmonary critical care specialist who has an interest in post-PE care and chronic pulmonary hypertension. So they take over care for us. So I followed them during the course of hospitalization, and then I turned their care over to the pulmonary critical care team.
I'd say that the way that that we do it, we will follow people post procedure. I usually see people 2 weeks out from their procedure in the office, and here we're sort of the gatekeepers at getting them to where we think they need to go next. So if someone doesn't have an obvious modifiable VTE risk factor, we'll get their referral to hematology. I know the pulmonologist would prefer to see the PE patients in clinic as well, and the follow-up hasn't been very good. So we also sort of try to organize the follow-up with pulmonology as well. But we were usually the first person that they would see after they get out of the hospital.
We are certainly far less organized in Evansville about the follow-up. I'm really intrigued by WashU, your post-PE clinic. That actually really caught my attention as something that I think is a fantastic idea that a lot of patients here would benefit from. But we do not do that currently.
All right. Well, we do have a couple of questions. I'll get on with that, and then Angela, I agree. We're very aggressive. We have a very aggressive post PE clinic. We see them all at 1 month, 3 months, and at 2 years with echoes and VQ scans. At 2 years to make sure they don't have chronic thromboembolic pulmonary hypertension. Fortunately for us here at McLaren, we now it's really gotten over to our pulmonary hypertension team. But initially, when we started doing them, us as vascular surgeons were the ones that actually followed them, and then really felt that would be, because the goal was ultimately to drop your chance of getting CTEPH, and that's really the goal, the long-term goal, frankly, outside of the acute process. And so we actually get VQ scans on them at 2 years, and we've seen a decrease of that. But we have a couple of questions. I'm going to get on with this, and this is for the whole panel. If a patient has a PFO, does that change your algorithm for intervention?
So for me, one of the battles that we fight at TriHealth is a lot of the people that don't actually perform the interventions really push back on the need for a transthoracic echo before the procedure. We, like I said, pretty much every patient we're doing a procedure on will have one beforehand. I think that one of the pieces of the puzzle that you want to know before you do this procedure is whether or not they do have an intraatrial shunt, because for me, that does change what I do. That is maybe one of the few situations where I would be more aggressive about putting a longer sheath up across the right side of the heart, especially if you're lollipopping thrombus while you're doing your thrombectomy procedure. I certainly don't want to drag that across a PFO and potentially, have a paradoxical embolus. So that would be one of the situations where I would potentially use a longer sheath knowing they have a PFO.
Yeah, we typically find that in the procedure when it senses that the wire's not going in the proper anatomy. We have taken care of a couple of paradoxical emboli, so we obviously knew going into it that they had a PFO. One time we actually struggled so much we had to have the anesthesiologist, it was an extremely sick patient, do a TEE to help guide us in the proper direction, because it was just a massive PFO and it was extremely complicated. But normally we don't really treat them any differently. We typically park a sheath in the pulmonary artery. So that's not a big change for us.
I assume everyone has one, so I always put my sheath in the main PA.
Go ahead, Courtney.
All right, so this is specifically addressed to Dr. Martin, but I think if anyone else has answers as well. But how can I never have to do CPR on a prone patient? What did you learn from this situation, and what can you pass on to us? And I think, I was also thinking, like, you mentioned you've learned a lot from difficult situations and complications. So can you share some tips and tricks from maybe that case and others?
Yeah, well, my therapist and I have talked about it quite a bit. No, it was just an awful time, and of course, it was in 6 a.m. with a skeleton crew. So what I learned is, I do prefer the up and over approach. I feel like I'm less likely to snowplow the clot to the heart. And so, that has been one option. And it also allows me, like I said, to clear the profunda vein, which I think is important. I don't put a filter in beforehand. That case in particular, that was a phlegmatic leg that came in after 3 PEs that night. So I just put an ECOS catheter in to kind of buy time and debulk stuff quickly, and then let that lyse for several hours, and then I did it. And I think that may have been the problem, is that I kind of loosened up the clot, and then it more readily went north. Really bad experience. But one of the mistakes I made then is I quickly, when we were trying to get the bed in to flip them, lost my popliteal access, which is probably just as well. That would have been really tricky to manage a PE from the popliteal vein. But I was able to get jugular, a sheath in the jugular, and then quickly spin a pigtail in the main pulmonary artery, which helped to quickly break some of it up. And then we were able to kind of treat it as a normal PE, and again, the patient did fine. They got rapid CPR, but it was just an awful experience for sure.
Thank you.
To kind of add to that, well, thankfully haven't had to do CPR on a patient. I have experienced an embolus from thrombectomizing. I think what I've done is transition to doing most of my patients supine, and then accessing the popliteal with the frog leg position. I think it just allows you to have all the different access points available. So that's just one thing that I've kind of moved towards primarily.
That's a good point. Yeah, me too. If I'm doing that approach, it's a good point.
There are a couple of questions. I'll kind of put them together. Really is one, obviously we're not trained this in our training. So how do you learn these skills for people that don't already know how to do it? I mean, are there specific courses for these? Did you guys learn on the job? And then how do you get involved with a PERT if there is already one that is non-vascular surgeon based, let's say at your facility? Do you have any tips and tricks to get people that want to get involved in this? Let's say that's either already established or they just don't know the skills as of yet.
There's no accreditation, and that's going to be the argument that's going to be.
I don't know as far as training courses. I'm sure they exist out there. My mentor Pat Mock has been sort of involved in treating PEs for about 12 years now. So I learned everything in fellowship.
So I have a feeling
Did anybody outside of you, Adam, anybody else learn it in fellowship?
Yeah, I will say, I mean, I learned when I was in residency, we did a lot of PE, but we did lysis, not the thrombectomy. So I do think there's some nuances to that. And I think, it's important. I mean, since then, I've just kind of reached out to people, like some of the panelists here, and sort of informally had discussions about it. But I think courses would be a great idea if they are available.
Well, I'm sure there are multiple of those sponsored by industry, and I'm sure Penumbra has one, but I'll let them explain that if there is one that's available.
All right, so moving on to another question. We had a question from the audience about thoughts on the Inari versus the Penumbra. Their group's done a large volume of these procedures and have found Inari to be more successful and with significant decrease in blood loss, maybe less procedure time as well. Do any of our panelists have experience with both and could comment on that?
I'll say, in my opinion, for Inari, obviously there's times you can't use it when there's an IVC filter, or if you don't have a clear pathway to get their equipment basically up to the level of the heart. There are times when I do think it might be a little bit more effective for certain more chronic clot, but I am very concerned about valvular damage and just kind of the lead pipe veins that may result from Inari use. I'm not totally convinced, but I'm concerned.
Yeah, I would add to that. When Inari first came out, we joined their clout registry, and we're one of the higher enrollers. And actually, when the initial follow-up, a lot of these patients, we started noticing some rethrombosis rates. And initially, we blamed ourselves and really looked at the images and couldn't really identify something. And then started speaking to other people across the country. It seemed like there has been a kind of common trend with that. So that kind of made me move away from the Inari. I know there's some newer technology as well, but I think with the Penumbra, haven't had that problem. So like for at least for iliofemoral DVTs, I can't speak on PE. Have primarily utilized in terms of the blood loss. Yeah, I'm not sure, in terms of relevant blood loss, how much there is with the Penumbra. I know the canister can sometimes fill up, but I think I think there's more to that, less to that than I think is made to be. I mean, I've never had to transfuse a patient from a Penumbra case. Maybe others have, but hasn't been a major concern.
I will say I didn't get to really touch on it, but regarding PE, I think one of the things people often bring up, kind of heavy Inari users, is the ability to use flow saver and give that blood back. And there is some pretty good data to show that when you give back unwashed shed blood, it's not compromised. So it's not like you're kind of giving back exactly what you lost. And it hasn't really shown to decrease the need for post-procedure transfusions. When you use the Inari device, it hasn't decreased the amount of adverse events that occur from that either. So, I think that's one of the things. Having a device that can sort of just mitigate blood loss from the get-go is why I'm more of a believer in that, as opposed to knowing you're going to have blood loss and trying to give it back, knowing that it's potentially compromised blood.
All right, thank you for that. How do you? I'm going to kind of bring lytics into the conversation here. How do you deal with PEs that are quite distal? So not main or saddle PE or main truncal PE, but those are like showers distally into kind of a distal vascular bed. Do you feel comfortable reaching those with the current thrombectomy catheters, or do you just plan on anticoagulating those patients? What is your management treatment for those? And in Europe, well, I guess this dovetails to it. Are there any patients that you think lytics or ECOS works better than thrombectomy, or is everybody now fully thrombectomy prone and less lytic prone?
If someone has centrally located thrombus, universally, we'll start with a thrombectomy. We've spoke at multiple conferences about pretty much eliminating the need for adjunctive catheter-directed thrombolytics with these newer devices that are very effective. We very infrequently will lyse patients. I think if we have a patient that has a PE, it's not centrally located, they do have some right ventricular systolic dysfunction, and sort of other people involved in PERT feel like they need a procedure, those would be maybe some of the patients we would take and just lyse them. I'm not sure how other people do it. Sort of our catheter-directed thrombolytics protocol for PEs is we get the catheters up, we run lytics sort of anywhere between 6 and 12 hours, and then the catheters come out in the ICU. We don't do any kind of follow-up. So I think the other pitfall, or the other thing that I don't particularly care for, is that you don't really know what's been cleared and what it looks like sort of when we're done with that procedure. But certainly lytics for someone with centrally located thrombus wouldn't be what we would start with.
Yeah, same here. I think ECOS is in our institution at this point mainly for the more distal clot, as you mentioned. We wouldn't, for a central clot, hardly ever do that anymore.
All right, so we're getting close to the end of time here, but one good technical question. So when you're pre-closing the vein, I guess do you have any tips and tricks on the pre-close? And then I think similar to that, can we go around with the panels and say like who does use pre-close, who doesn't? And I think Dr. Ricker, you mentioned there is some controversy of like to do it or not to do it. So I'd love to hear everyone's opinions on that.
Yeah, so I mean, like I said, for us, we're pretty aggressive about getting them back on therapeutic anticoagulation, and it can certainly, not that this is the most important thing, but it can, productivity in the cath lab can certainly come to a grinding halt when people have to hold pressure for a long time. I guess the good thing about using proglides in a vein is if they fail. It's not like them failing after you just did a hard endovascular aortic case and you're cutting down on groins and it's kind of hectic and not controlled. Deploying the same way we do in an artery, if for some reason it fails at the end, then someone's doing what they would have been doing otherwise. So they're just holding pressure, you're putting a purse string in or something like that. But you know, usually when the controversy arises from maybe some unnecessary cost is what people have a problem with. No one's fussed at me, so I guess spend it if you got it.
When you do the ProGlide, do you do it sort of in the standard way you would for an artery where you pre-place them before you upsize your sheath?
Yeah. So we get access and then over a Benson wire we put 2 ProGlides into the common femoral vein, and then we'll put an 8 French sheath in, and then we'll get an Amplats in, and then we'll go ahead and upsize to a 16 French. But yeah, we place them at the beginning.
I've done it both ways over the course of years, and I did not find there to be any difference between bleeding risk from both. I use a purse string suture around the access site at the end, and I have never reversed at the end of a venous case, and they remain on anticoagulation. So for me, it doesn't change anything, both in terms of anticoagulation, bed rest, and postoperative care. And since it did not change outcomes, I stopped using Perclose after trying it for a long time.
Yeah, I do pressure. I have had to intervene on another partner's, narrowing of a vein. But you're right. I mean, even if you do have to intervene, angioplasty or something like that could, be adequate. So.
Luckily, we haven't had any issues where we've had, a thrombosis of the common femoral vein from the ProGlides, and we'll have to figure out what other people are doing because we have certainly had some hematomas form from manual pressure when people get back up to the floor. So nothing that we've ever had to intervene on, but uncomfortable groins for patients.
A big purse string, very deep.
We're getting to the top of the hour, so I just got information from Penumbra there are training courses, including simulated cases. So reach out to your Penumbra reps, or you can, and I can't find a way to put this into the chat because I can't do it, but it's medical education at Penumbra Inc. That's penumbrainc.com. So medical education at penumbrainc.com. Or reach out to your Penumbra rep, again, for those that are interested in looking at this. Okay, well, we're at the top of the hour. Along with Dr. Morgan, I want to say thank you all for joining us. Thank you to our panelists for being with us. Thank you to our participants and for our attendees. And thank you to Penumbra for sponsoring this and for the Midwest Vascular. So I don't know if you have any closing remarks, Courtney, but thank you all for spending your evening with us, and thank you all for the panelists.
I echo the same remarks. Thanks, everyone. Have a wonderful rest of your evening, and hopefully we'll see a lot of folks in September.
Good night, everybody.